Good afternoon, or good morning, or good evening, wherever you may be coming from today. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. Years ago, we were looking at different cohorts of patients that may or may not be getting enough attention. And in this case, it was pediatric and young adults that we're in the MPN, space, but we weren't hearing a lot about what was going on in that field. And we connected with Dr. Nicole Kucine, who is from Weill Cornell, and Dr. Linda Resar from Johns Hopkins. And we have such a great partnership with them. You may also see on the screen Cam, who is in his 20s now, but he was diagnosed in his teens with an MPN. He's going to share his story, and if you have questions for him too, you're welcome to share those with us and we will ask him. For now, we're going to start with Dr. Resar and let her share what's happening in research in her at Johns Hopkins and any other information she'd like to share. And then we'll hear from Dr. Kucine, and your questions are welcome. So Dr. Resar.
Hi, good morning, afternoon, or evening to all of you. It's always a thrill to be here and be part of this wonderful group. Like Nicole, I'm trained in pediatrics and in hematology oncology. And when we started, we were about the only two pediatricians super excited and interested in MPN in children and young adults and what we can do to help. And I'm going to let Nicole talk about a recent exciting paper that was just accepted today that we had the wonderful opportunity to work on together with international colleagues that focuses precisely on our younger patients, how to prepare them, to transition to adult clinic. So I'll let her take care of that because she did a beautiful job leading that. My laboratory studies MPN, and in particular, we're very interested. Why does it present in our young patients so early versus older patients late? Like I have a mom who's 89 and she has MPN. It took her quite a while to present. And I think one of the most exciting areas is we now know that some of these mutations are actually occurring in utero. So the million-dollar question is, why did Cam develop it when he was a young man, adolescent, and why do some people develop it in their 80s? And it's not going to be a single answer. There are going to be multiple contributing factors, but we are particularly interested in what those factors are because we want to get you all the best treatment to sort of put a block on those factors and prevent this from happening. Or for people who develop it and present with an MPN, what can we do to disrupt that process, stop it in its tracks, get your blood counts normal, and make sure you're feeling well? So in particular, my group studies a protein. It's called HMGA, or high mobility group A chromatin regulator. And we know that this protein is essential in blood stem cells that have an MPN mutation like Jack to cause an MPN phenotype. So one of my pictures in my office there, that one is actually a mouse who gets MPN. And we know when we take away a little bit of this protein, about 50%, the mice are perfectly healthy and have normal lifespans, but they can't get MPN. So we're trying to understand what it is that this protein does to prevent the mutant stem cells from expanding, making more cells, and then causing elevations in blood counts and the associated problems that you all feel when you present with MPN. And we're also very excited about some of the new therapies on the horizon. I know some of you are getting different interferon treatments, and we have some super exciting studies ongoing right now where we are collecting samples, blood samples on young patients in particular, newly diagnosed patients who haven't been treated with anything, to see what's going on in their blood cells that has made them present with an MPN. So we're doing something called single cell RNA sequencing, which allows us to look in individual cells. And we can say, well, what's turned on in these cells and why are they proliferating too fast? And we're also investigating the effects of interferon, in fact, Besremi, one of the newer forms of interferon. And I know Nicole and I were so thankful when that became approved for patients because it can be given every 2 weeks and even up to every 4 weeks. And especially for our young patients who are really active in, elementary school, high school, college, who wouldn't prefer to get a dose once every 2 weeks or once a month? So that treatment, I think, has really revolutionized the lives of our patients. And it's not just for young patients. My mom, who's 89, is also getting it, and it's been great for her. She used to have to take a whole day off from her activities and get phlebotomized. And so we're also, as part of our study, we're collecting samples on patients, young patients with MPN, and then we're starting them on treatment. And when their counts stabilize, we're collecting samples again to see what exactly is being targeted in these blood cells to normalize the blood counts. And one of the things we're looking at in particular is the protein that we study, but more importantly, we're looking at like what are the signals in the blood cells, because we want to learn as much as possible about how we can prevent those mutant blood cells from bad behavior. And we consider bad behavior making too many blood cells and making our young patients sick. So, we're really excited about this. I'm super excited about Nicole's new paper. She's doing just a beautiful job, as you'll get to hear about. And I'm excited about this meeting because maybe 5-10 years ago we were the only ones interested in this process, and now with more accessible genomics, we know there are a lot of young people with these mutations. And so I think it's a good time to be in the field, and I think we're really poised to do a lot to help all of our young patients stay healthy. And we really want to do what we can to beat down those mutant clones.
Fantastic news, by the way. This is amazing. And Nicole, I'm so proud of you and Linda. And we're very anxious to hear about this paper and Dr. Nicole Kucine.
Hi, everybody. Thank you, Anne. Thank you, Linda. So Linda talked about some of the stuff that we're interested in and that we've worked on together, especially interferon as a treatment. She mentioned Bezremi, which is the FDA-approved interferon agent, which is great. And something Linda and I are actually working on with the company that makes that is trying to work with them and the Children's Oncology Group to actually develop a clinical trial so that we can figure out the best way to use that medicine in our young patients, because right now it's only approved for people over 18. So that's great for someone like Cam's age, but for a 5-year-old, it's not something we're totally sure how to use yet. So the way you learn that is through a clinical trial. So that's something that I think is really important, and that we're in the early stages of trying to build together with those organizations. And so that's really great. And Linda mentioned some things about single cell sequencing, which is super important, because I think that's one of the key questions is, why do some people present at a young age? And I think one of the nice things, so I agree with Linda's point that this really wasn't something people recognized 10 or 15 years ago. And I think one of the best things by working on it that we've been able to do is really raise awareness among other physicians. Like, I think everybody on this Zoom probably recognizes that MPNs are rare in young patients compared to the 70 and 80-year-olds, but we're now starting to see them more and more. I think some of the reason for that is because pediatricians do a lot of blood counts in otherwise healthy kids and pick up these incidental high numbers. But I also think now people are starting to think about it earlier when a young patient presents with a blood clot in an unusual place, or when a young patient has high platelets, which honestly in pediatrics we do see a lot, but maybe it's not just the routine thing, maybe it's something else. So I think we're starting to test younger patients more, and I think that's partly because of the awareness, which is great, because I think, information is power. And so if you have something, we can work with that. So I think it's been really nice to see the sort of increased awareness in the field. And so one of the things that Linda and I and some colleagues of ours felt was very important is that because these are rare, one, I think a lot of pediatric hematology oncology doctors don't have a ton of experience caring for young patients with MPNs. And thankfully, pediatric medicine is very humble, and people are always willing to reach out to colleagues and ask questions and reach out for help. So that's great. But, we got together with some colleagues in a couple of different countries in Europe and both in adult and pediatric medicine. And we thought, what might be useful for fellow clinicians out there. And so one big area of medicine that is not specific to MPNs, but is certainly important for MPNs is something called healthcare transition, sort of the process of moving from the pediatric medical space to the adult medical space. I think anybody, Cam can certainly attest to this, anybody who's been in pediatrics and is now in adult medicine and remembers what that's like. The adult clinics are very different. How adult medicine works is very different. Who the doctors and the nurses and the team will primarily contact, the parent versus the patient. There are different things about adult medicine, like a lot of clinical trials that are open to young adults and adults that may not be open in the pediatric space. So it's really a different experience. And so we got together with this international group of adult and pediatric doctors, and we created what we called a toolkit to help people with that transition process. So there's 3 elements to it. So one was just a kind of straightforward checklist for physicians. We figure if physicians don't have a ton of experience with this, knowing what to educate their patients and their parents on might be hard for them. So we created a checklist for physicians to say this can help guide how you educate your young patients, so that if you don't have a lot of experience with this, now you know what's important to make sure they know. Then there was a piece specifically for patients that's called a readiness assessment tool. This is something that's used in all different areas of medicine, where you can work with a teenage patient to help assess how close they are to being ready to move to adult practice. So, what knowledge do they have? How important do they think this is? And it's disease knowledge. It's also about things like, I know what my insurance company is. I have an insurance card. I know how to get to my clinic. I know how to set up an appointment. I know how to get a referral. Things that when your parents do for you, you don't really know. And you have to learn that as an older teenager and young adult as you move to adult practice. So the American Society of Hematology, very conveniently, had developed a general hematology readiness assessment tool. And then they had made forms that they adapted for sickle cell disease and hemophilia, which are much less rare hematologic diseases. So we used their general hematology form and adapted it for MPN patients. So we have a checklist for physicians to guide the education they provide. We have an assessment tool for patients to use to really work with their physician and see what are the gaps in knowledge, how close are they getting to be ready to independently care for themselves as their, primary healthcare person. And then the third piece that we thought was really important is that, there are differences in practice, right, between pediatricians and adult providers. And so we thought if there are some elements of care that we can all agree on that would make things a little more continuous in the pediatric and adult space, that might be really nice, right? So a lot of times pediatricians might be nervous when they see a high platelet count and take a perfectly well asymptomatic person who has a high platelet count but may not necessarily need treatment and start them on a treatment. But then in the adult space, they might say, you don't need this. So we figured if we could come up with a little consensus, so it's not a formal practice guideline, but it is just a consensus among a group of 9 experts saying these are things as adult and pediatric MPN experts that we all think make sense for our patients. And we wrote that out. And so I think that'll be really helpful for both pediatric and adult providers who don't have a ton of experience with young MPN patients to sort of give them some insight into treatment. So we used questions that we get asked a lot to sort of guide that guideline and provide points that we think could be helpful to have, agreement between pediatric and adult. And again, it's not like a formal guideline. To create a formal treatment guideline, it's a very lengthy and standardized process. And I will tell you that the European Hematology Association, EHA, is actually working to develop a standardized guideline for the diagnosis and management of patients with MPNs under the age of 25. So that'll be great. It, takes a long time to make a guideline, but that is something they're working on, which is really exciting. But this, I think, is a nice thing to have as an international adult and pediatric collaborative that can give some doctors a little bit of guidance if maybe they don't know the right people to contact, or if they don't have a lot of access to colleagues or to medical reference. And we're publishing it open access to make sure that anyone can get to it. You don't have to necessarily have a subscription to the journals, to make sure that if somebody's in a low-income country or if they're at a community practice where they don't have access to a lot of, academic journals and things, that they should still be able to get this information. So we worked with colleagues from France, Italy, and Germany, and this was just accepted for publication yesterday. So it's really well timed. So that'll come out sometime in the next couple of months, and that's great. And again, I think, it's just the first step, but I think having that sort of toolkit of helping guide physicians with their education, helping patients sort of decide, am I getting all the information I need? Do I feel like I'm getting to the right place to transition? And then having some consistency in basic management recommendations, I think will be a useful thing. And, next steps will be having patients like Cam and other adolescents and young adults test that tool and give feedback and help us revise it for future versions and things like that. So it's just something that we were really excited about, because I think anytime you can do collaborative work internationally is great. Anytime you can do collaborative work between pediatric and adult medicine, I think is really important. And this was something that had not been addressed or touched on before. So it's really the first, I think, foray into healthcare transition for the MPN population. So I think it's really exciting.
Extraordinarily exciting. And that's all I can say is it's extraordinarily exciting. Both of the things that you two have shared so far, this is fantastic. It really is. I would say, perhaps we could host another event where we have just physicians attending. And so MPN docs, that are not from the major academic institutions necessarily, but they're welcome to join. But we have a lot of doctors in our database that see MPN patients that you would never know. And they are definitely a target audience that could benefit from this. So my first question to both of you, my son was diagnosed with ET at age 9. He is now 13. We recently started Pegasus due to his platelets rising and increasing headaches. We are now in week 10, excuse me, of interferon, and his platelets have not fallen. How long do you recommend trying interferon before calling it a failure?
I mean, it can take months to really see the counts go down.
Oh,
And so I don't usually say something isn't working. I give it at least, honestly, 3 to 6 months to really try it. Also, often people, at least in my experience, who have been on the Pegasus interferon, usually can get by with just the first dose, the very lowest dose. But certainly you can increase the dose. So certainly if someone is not responding in the way you want, or if their symptoms aren't improving, I worry more, unless someone's had like a major blood clot or a major bleeding event. Depending on why I started it, I might worry more about the symptoms than the platelet number itself. And so if somebody's having symptoms and they're not responding after a month or two to that first lowest dose, I might try going up a little. And you definitely have room to go up on the dose of interferon. So I don't know if I would call it a failure at that point, but I would say there's probably room to make adjustments if he's not feeling better.
Linda?
Yeah, and I would just echo what Nicole said. And in particular, I think it's actually very interesting. One of the things I've noticed with my young MPN patients is that in many cases, the young people with the milder phenotype, and we consider ET to be the most mild phenotype for MPN, they often take the longest to respond. And there's some really exciting research that suggests that these stem cells that are giving rise to too many platelets are actually a little bit more quiescent, which means they're kind of chilling out. They're not cycling and making, as much additional blood as somebody who might have polycythemia vera, like someone who's making too many red cells. We consider that a little bit more of an advanced stage of MPN. Some of our patients start out with ET and make too many platelets, and over time start to make too many platelets and red cells. So it may be that people who make too many platelets, ET, have more stem cells chilling out. And when we give interferon, what we think is that this medicine is coaxing those chilling out stem cells to cycle and then exhaust themselves. So I've noticed in a number of my young ET patients that you would think, oh, it's milder. Their problems usually are much less severe. They should respond quicker. But I can say, because those stem cells might be more what we call quiescent or chilling out, it may take longer. So don't worry about 10 weeks is very early. And, just as Nicole says, there is room to adjust dosage, and hopefully at some point soon you could be offered Bezremi, which tends to be a little more slow released, so tends to be better tolerated. But 10 weeks is really quite early. And so I would not give up hope at all. And just as Nicole beautifully said, are your son's symptoms getting better? Are his headaches getting better? Those are really the more important parameters than just the platelet count. Because we know from really great studies, and Nicole led some of these, where we looked at blood counts in our young patients, and the high platelet count, even though it's scary for people who don't know a lot about MPN, that by itself doesn't tend to be a big risk for anything severe. High red counts, by contrast, tend to be a big risk for clotting. But high platelet counts, although they worry people, don't seem to be a big problem for severe symptoms. They can cause some things like bleeding, but
And Linda and Nicole, don't we all have high platelets if we have an infection, like a bad cold or the flu or something?
or
That
iron
elevates our,
deficiency.
and that would elevate our platelets. I'm not saying that's the case here, but
Right.
all right, thank you. And moving on, have you seen growth restriction commonly in young patients who are using interferon, especially in those using interferon prior to puberty?
Oh, I was just going to say, if the mom whose son has the problem, feel free to reach out to Nicole and I. We don't have all the information just from the little chat, but by all means, we're always happy to help.
Oh, okay, sure.
And,
Doctors.
and have your doctor reach out to us if you want, because we get emailed from doctors all the time, and I'm always happy to
Yeah.
answer questions for the physicians also, if they don't have a ton of experience using the medicine or things like that.
And bravo to you too. I have never worked in a space, especially in cancer, where the doctors are so willing to be available to not only the patient, the parent, but also to each other. There's a collegiality
Pediatrics.
that is just amazing to me. And so, yay.
Peds is a different
Anyway,
world, Anne.
to answer this other question about the use of interferon in puberty and growth restriction, have you seen any of that?
It's a good question. I've seen the kids that I know who have started interferon before puberty. There are definitely a couple who are on the smaller side, and I don't know how much of that is their disease, how much is interferon, and how much is them. But I've also had kids who have started interferon before puberty, and I just heard from somebody's doctor who I haven't seen in a while that the kid is like 6'4". So I don't know sometimes how to tease out, is it the medication? Is it related to the illness? Is it something else, and just like your natural height? So it's a good question. And I don't think it's everyone who has ET, who is on interferon. So I have to think about that one more.
Linda, do you have any thoughts on that?
I was going to say, I was just pulling up my medical record to check on the weights, but I've seen patients, improve their growth on it, because sometimes, when one has MPN, if it's not treated, people can feel sick. They have some inflammatory signaling from these stem cells, and they can feel unwell. And so the interferon can actually, in some cases, once the counts are under control and the inflammatory signaling is better, actually grow better and develop better. So I've seen, more of patients' growth taking off once their disease is under control. And Nicole's absolutely right. Like, I'm 5'2". If I had interferon, I'd probably still be 5'2". So you want to look at the heights of the parents before you worry that a drug,
Yes.
a
Right.
drug is interfering. And some people, actually go through puberty later, and probably if someone's sick and inflamed, that could delay puberty as well.
Right. I think Linda makes a good point that often when people have more disease control, they often eat better, grow better, that sort of thing. And inflammation, I think, can affect everything in all different body systems, probably
Right.
including growth. So,
Right. Have either of you seen much of a problem with kidney issues with young MPN patients? No?
I have not.
Okay.
No.
I know there are some studies out right now. Dr. Rain, I believe, addressed this issue of kidney issues with, MPN patients. So I just wondered if you saw that in the younger cohort of patients, but
Thankfully, I
okay.
haven't.
Yes, thank God. All right, I'm in the UK. I wish I was in the I'm in the UK and have a 2-year-old daughter who has had high platelets since discovered by chance at 8 months old. We test every 3 months and it has stayed high. She is triple negative and has not been formally diagnosed. How do we know if this could be an MPN or not? Doctors here do not want to do a bone marrow biopsy and not sure what age is acceptable to perform one.
So I will say I would personally not perform a bone marrow in a toddler with high platelets if they do not have a genetic driver, like a known JAK2 mutation. High platelets in toddlers is unbelievably common, so much so that what's normal, like the blood counts can vary by age. And while we say that in general, the standard platelet count range of 150,000 to 450,000 is pretty much the same for everyone. We know that infants and toddlers have higher platelet counts than that, and even like 600 to 700 is not unusual, just because even if they're healthy, like they're exposed to so many viruses and their immune systems are developing. And what Linda was mentioning before, something called, Anne was mentioning, I think, something called reactive thrombocytosis. So it's normal, especially in kids, like even more so in kids, that if you get exposed to any, viral environmental thing, your platelets might go up. So it's very common to have high platelets in toddlers. Little kid bone marrow is super reactive. So often also little kids, like if they get RSV or the flu or something, they could have these crazy high platelet counts of over 1 million. And the pediatricians ask us, do we need to do anything? And we say no, like just keep following it. So if I was seeing a otherwise perfectly healthy toddler with a platelet count, between 500 and 1 million, who did not have a genetic mutation, I would not be in a rush to do a bone marrow either personally. And part of the reason is because, especially for triple negative ET, we generally don't treat those patients unless there's a clinical indication to do so, like a blood clot or a symptom that is not being managed otherwise. So because there's no treatment that needs to be done, I think watching and waiting a kid that age is something I would do in my practice.
Linda?
Yeah, and I would just echo everything that Nicole said. And one of the most common reasons for a reactive high platelet count in a toddler is iron deficiency. So, I don't know the details of the little one who's a toddler with thrombocytosis, but hopefully that's been looked for. It's very common in young little toddlers, especially some toddlers tend to really love cow's milk, and that can cause a little bit of bleeding in the gut, and that can cause iron deficiency, and then the platelet count goes up. So, be sure to touch base with your pediatrician and, make sure that your little one is evaluated for iron deficiency, because that's one of the most common causes for it, in addition to different viral illnesses. And yeah,
Fantastic. Yeah, good
well,
response.
yeah, and I was going to say, Nicole and I, certainly as pediatric hematologists, oncologists, we've certainly performed marrows on babies who are newborns, but I agree with her. If the genetics are completely normal, I wouldn't feel pressed. I would feel more pressed to see we would call this most likely to be secondary, and to look for what those causes might be, like the infection or iron deficiency or something like that.
Right. If you get to the point where you need a bone marrow at 2, it's very easy to do that. I don't usually feel like I need to do it again in a healthy kid. I watch and like monitor the counts, a couple times a year. But something will have to then change. Either I think something is different about them, or their other counts are changing, or something would have to drive me to do the bone marrow in that setting, I think.
Great answers. Thank you. This question is, our son has ET and has had melena, I don't know if I can say this, hematogesia. Did I say that correctly?
Hematochezia, yeah.
Oh, sorry.
Close, Anne.
Over the past year, his workup was inconclusive for acquired von Willebrand's. We stopped aspirin for 1 month and the melena has stopped. What is the riskier, stop taking the daily aspirin or allow him to have some GI bleeds?
I don't like GI bleeds. I don't know about Linda, but
No.
I mean, I guess, I just to take a step back about the use of aspirin and MPN. So the only patients that I put on aspirin, like in my pediatric practice where I see children age 0 to 21, the only patients I treat with aspirin are either those who have a JAK2 mutation or those who have sort of vascular symptoms like significant headaches, erythromelalgia in their hands and feet, where aspirin might be beneficial. In my patients with CALR mutations and my patients with MPL mutations and my triple negative patients, I do not start aspirin because I don't worry about clotting based on the height of the platelet count, but I would worry about bleeding. So if you have someone who has a JAK2 mutation and can't take aspirin because of bleeding, then yes, that's where you think about cytoreduction with interferon, with hydroxyurea, with some kind of medication to lower the counts to decrease the bleeding. But I don't use aspirin in a lot of my young MPN patients because I don't think it's indicated for them. And I know some of the adult guidelines talk about, low risk patients taking aspirin, but I don't have a reason for a kid with a CALR mutation or triple negative ET to be on aspirin unless there's a symptom I think aspirin will help. It might harm them. And so I don't usually use it in most patients.
Linda, do you have anything to add to that?
Well, the only thing I would add is sometimes, and it's actually a bit more common in boys, but sometimes constipation and a diet that's not high enough in fruits, vegetables, and fibers, which is tough in the wintertime when these things aren't so readily available, that can cause a little bit of constipation. And, things like hemorrhoids are relatively uncommon in young people, but you can even get like a little fissure just from a bit of constipation, and that can cause bleeding. And then if you are taking an aspirin, and again, I agree with Nicole, I tend to use it more for PV and for patients with some vascular symptoms, but that could make the bleeding even more. And sometimes high platelet counts can contribute to bleeding with an acquired von Willebrand's. So it might just be if there is a little tear or fissure, we call them fissures, some dietary changes could be indicated to sort of circumvent that bleeding. It's not that uncommon, but you probably want to go to your primary care provider and just, have somebody take a good look at your son's bottom and, review his diets, because it might be a pretty simple thing that could be done to try to fix that.
Yeah.
And hydration is really important. I find that
Hydration.
like
I just read an article about
adolescents are not the best at and
horrible.
early adolescents are not the best at hydrating.
And elderly people. I just read this article about young people and elderly people. I mean, I remember playing outside in the summer from 8 in the morning till 5 in the afternoon and never having a drink of water,
And nobody wants to like be the kid who stops to take some water. Nobody wants to get up
or
and go
go
to
to
the
the
bathroom in
bathroom.
school. Yeah, no. So I think
Exactly.
hydration is also important to go with what Linda was saying.
Absolutely.
For
All
a
right.
lot
So
water,
Right. We all have our water bottles, right?
yeah,
yeah,
we
water bottles.
do. I've got mine right here.
Yeah.
How often do you do a bone marrow biopsy on your ET pediatric patients whose counts are stable and symptoms are stable? For screening purposes, our oncologist is suggesting every 18 months.
So I don't personally do that. So that is something that will be in our published paper that we were talking about
Yes.
before.
Yeah.
So the things that drive me to repeat a bone marrow are either there are changes to the patient, meaning new clots, spleen is getting bigger, counts are starting to rise, or anemia is developing that wasn't there before. Something about the blood counts makes me nervous. Or one of the labs I follow is an LDH. It's a number, it's sort of a somewhat non-specific enzyme in the body, but it often will become elevated if disease is progressing. So it's something I trend. And if I see that sort of steadily rising and becoming an elevated number, that is something that drives me to do a bone marrow. But I will be honest, I don't do routine screening bone marrows in kids on or off treatment if they're doing very well. Their counts are stable, they're feeling good, and nothing new is going on because I'm
Yeah.
not totally sure what I'm looking for.
Excellent.
I guess I will add with a caveat that I think, we have some data now that the patients with CALR mutations tend to be the ones who progress most in younger patients. So you could probably make an argument to maybe do one or two during the pediatric period in those patients if everything is stable, but I honestly don't routinely repeat them unless I feel like there's a clinical indication. I don't know, Linda.
Linda?
Yeah, I agree fully with that. And for in our paper that will be coming out, we've made the recommendation at diagnosis for our youngest patients. And I guess Nicole got me thinking because she mentioned CALR, and although some of these therapies are not yet available for pediatric patients, there are some new exciting therapies for CALR MPN that include antibodies directed at the CALR receptor to prevent the excess signaling. And so maybe as these things become more available, there might be good reasons to take a look. But as long as our little ones are doing well, our young patients are doing well, I don't feel pressed to get marrows. And similarly with older patients, even, they're doing well. A lot of times we like to get it at diagnosis in children and young adults, and only repeat when there's something that worries us with regard to their counts. And with the caveat about CALR could progress. And now that there's new treatments on the horizon, it may be indicated to take a look before you start such a treatment.
You mentioned clinical trials. This person wanted to address that and ask how they get their child into a clinical trial for MPNs.
So there isn't a clinical trial. Well, okay, so let's take a step back. I guess there are, so when we say clinical trial, that generally refers to a study with a drug where someone is testing a drug, either initially for safety and tolerability or beyond that for efficacy and benefit. So that is usually what I think people mean when we say clinical trials, and that's what I was referring to before, for example, with a lot of new drugs coming out in the pipeline for adults. So there are no open drug trials for children with MPNs currently for any of the newer agents. That is one of the reasons we're very excited and hopeful to try to develop one with Besremi, because I think that would then be the first tested and potentially, really studied product in a young patient. Anyone 18 and older is usually eligible to enroll on a clinical trial. So if someone is seeing a pediatrician for their MPN and they are 18 or 18 to 21 or 18 to whatever their hospital allows, and they're interested in learning about new clinical trials, their pediatric provider may not have any of those open or be involved in them, but they can absolutely have a visit set up with their adult colleagues who are probably the ones who are involved in all the clinical trials. We have a lot of clinical research studies opened for children with MPNs. Like I have a registry open where we have over 50 or about 60 now young patients with MPNs who have enrolled, CAM signed up, which is great. And that's how we are able to do all these things where we learn about patients and learn about how clots develop, how interferon works, what to expect clinically in these patients. So anybody who's interested in having themselves, or, if they're a young adult or their child on our like clinical registry study and be involved in things where we're trying to learn about sequence mutations and different genes in MPNs and thrombosis and drugs and all sorts of different things. That is open, and you can email me and I'll put my email in the chat later and Anne has it. But there are currently no, that I'm aware of at least, therapeutic, meaning drug clinical trials that exist for children with classical MPNs at this time.
Okay.
Is that a good way to sum it up?
Yeah, that's a great answer. Linda, anything to add to that?
Perfect.
Okay. Moving right along. Can slower mental processing as a child be a result of ET? Our son is a straight A student. However, it would take him 3 hours or more to do the same amount of work as other kids. Linda?
Can't say that I've seen any evidence to suggest that cognition and ET are linked. But, one could imagine if somebody has an MPN and has some inflammatory signaling and isn't feeling well, just like if we get a cold or flu, we might, not be able to process things quite as quickly. And also some people just naturally take longer to integrate knowledge and respond. And, I have to say in my research team, some of the people who take the longest time to put things together are able to respond the best because they're actually considering everything in greater depth. So I haven't seen ET and cognitive defects or cognitive slowness linked. Other than, in children who aren't feeling well, sometimes that can be the case, just like when we get sick with a cold or flu.
Pam, I just want to throw that question at you for a second. I know you didn't have ET, but did you have any problem, like processing your schoolwork, or, was it the fatigue that made you too tired to look at it?
Yeah, I don't know if there's any direct correlation, but I suppose, yeah, like when it comes to fatigue, that could definitely play a role in how you're going to be able to workload, but manage. But, at a younger age, I would assume no, but I don't know, obviously.
Yeah, you probably didn't. Nicole, anything else to add to that?
No, I've had a couple of patients talk to me about some concentration issues and things.
Yeah,
And, certainly if you had any kind of like blood clot in your head or, something like extreme like that, yes, I could definitely see that could always have potential problems. But it's really it's not something I've seen in a ton of patients. And I will say I don't know, sometimes it's hard to tease out how much is I think similar to what Anne and Cam were saying, like, and Linda mentioned, like how much is the underlying diagnosis versus, the other things like the fatigue, how much, if you're having headaches, that can affect concentration. So is there other symptoms that are contributing to that? And then how much is other stuff like screen time and, visual, are you making sure your vision is good? Like a lot of kids we find need glasses that they don't realize because of, there's so much time spent doing computer work and things for school. Um, so I never say anything is impossible, but it's not, it's something that one thing I always tell parents is it's hard to do, but I think it's important to do is not just say you have an MPN, so everything is due to the MPN, but make sure
right,
that you kind of open all the other doors that need to be opened so we don't miss like a migraine diagnosis that can be treated, or, we don't miss an ADHD diagnosis that can also be treated. So I think making sure that there's everything is looked at and not just saying, oh, it's the MPN, because then you might be doing a kid a disservice by not, getting them another evaluation or some study that they might need that could be helpful for them in the long run. So,
right,
so I think it's good to sort of think about everything and not say it's definitely not the MPN, but not say it definitely is the MPN, and just kind of
yeah.
try to cover all your bases.
Linda?
Yeah, Nicole always jogs my mind whenever she's making her really brilliant comments. But the other thing that's really common in MPN is iron deficiency, especially if somebody's sort of a PV, ETPV. Sometimes they can be hard to sort out, or sometimes patients start with high platelet counts and then they start to make too many blood cells, but because they're iron deficiency, their blood cells remain lower. And clearly in children and young adults and even older adults, iron deficiency can make you distractible, irritable, hard to focus and concentrate. So that would be definitely worthwhile looking. And I'm sure Nicole, just like me, we do periodic checks for iron deficiency in our MPN patients because it's quite common.
I think you already answered this question, but I'll ask it and I think, and then we'll move on, but if a result is triple negative, how do you rule out or rule in an MPN? I understand that triple negative is more common in children, so how do you diagnose this? Is it a bone marrow biopsy, or how long do you wait for your child to have a bone marrow biopsy? What other tests can be done to rule out secondary thrombosis?
Um, I mean, I think ultimately, to really say a kid has triple negative ET, I think one, you need the bone marrow to be sort of consistent and look like ET. And you really need to say there's nothing reactive. There's not iron deficiency, there's not, just like a lot of exposures to cold and daycare, there's no celiac disease, there's nothing else going on. Because again, like in young kids, it's so common to have thrombocytosis and have your platelets go up because of any little trigger, that I think in some ways it's a diagnosis of exclusion, and sort of the formal diagnostic criteria really, like, you need to rule out reactive causes. And so I think the pediatrician has to, and the hematologist really need to think about anything else that could be going on and really ask detailed, reviews of systems, and ask about all the elements of like GI system and neurologic and stuff, just to make sure. And then, but usually if someone really is like a perfectly healthy child with nothing else going on and they're not iron deficient and they don't have any symptoms, and this was just incidentally picked up, and they ultimately get a bone marrow that looks like ET bone marrow, then they probably have triple negative ET. But I really think it is a
Yeah,
diagnosis of exclusion.
Linda, is that
Yeah, and
anything else?
the only other thing I might add is I had a young adolescent like that. Sometimes it can take a little bit of time for the underlying process to declare itself. So somebody with high platelets, otherwise everything looked great, no mutations. We look at the blood under the microscope, not necessarily a marrow, just as Nicole mentioned, unless, we've ruled out everything secondary. And this girl ultimately, 1 or 2 years later, was diagnosed with something called suppurative adenitis, which is infected lymph nodes in her axilla. And so she didn't really have clear evidence for that when her platelet count started to go up. But over the next couple of years, it became clear, oh, she's got these infections in her lymph nodes. And so that would be, as we've been talking about, a secondary cause for the thrombocytosis. So sometimes just time is needed for the underlying inflammatory process to reveal itself.
Yeah,
So-
everything declares itself eventually. I think
Right, no
is-
kidding. Just
And
wait
you-
till
And it-
you're my age.
Yeah, and again, for someone who has triple negative ET,
Yeah,
if they are well, we're really not going to do anything other than like observe them. So, I think there's a difference in saying someone had a delay in a diagnosis of JAK2 positive PV, versus saying we didn't officially declare something triple negative ET, because all it involves is monitoring. We don't really worry about clotting in those kids. We don't worry about progression in the same way as we do with the CALR patients. So the kids that I've met with triple negative ET, unless there's really like a clotting event or severe symptoms, we don't do any intervention. So you're not delaying a treatment per se that a child would get by not rushing to a bone marrow and really taking the time to wait and see if something else declares itself, like Linda said.
The other thing to keep in mind is young people with triple negative do really, really well. So that's another reason we're not in a hurry to rush in and say, okay, this is it. And some of you, I know all of us read the internet now when we get a diagnosis, right? And I just want to say this up front because I don't want you to worry. Adult patients, older adults, in particular, older males with myelofibrosis, when they have triple negative disease, that's a bad prognosis. But for a young person, it's good to be triple negative. So we're very positive and encouraged when we see triple negative. We're like, okay, phew, we don't really have a lot to worry about. Let's see how the young person does over the next few years. Let's see if we can identify a cause for the inflammation, but we don't worry. And you might read on the internet that it is a bad thing, but that's really more relevant to much older folks, and in particular males with big spleens and pretty advanced myelofibrosis.
okay. So one more question for the two of you, and then we're going to hear from Cam. And he'll share his journey with an MPN to date, and give us some, pointers for the younger people that will listen to this. Very often people will register, but then they watch this after it's been recorded. And I suspect that will happen with younger people who are students and who are at their jobs right now. But the last question for our doctors and our specialists is familial MPN. So many of us know that there are multiple studies and have been multiple studies about is it a genetic, situation in a family? And very often, I mean, Nicole, I think you were at this event where we had 5 people in the audience. Do you remember this? There was the mother, dad, and 3 kids, and they all had a blood cancer, every one of them, even though the parents weren't related. And so, there are 2 camps, in my experience. Some of the docs I hear from, and they say, oh, no, we really don't think that's the case. What are your thoughts about what you're seeing in young people? Is it a parent that has it? Is it a grandparent? Linda, do you want to go first?
Yeah, so I think this is a super interesting question. And I think I mentioned this earlier, my mom has MPN. So when we have large populations of people with MPN, there is a slight increased risk in family members. And now that we're learning more about why someone of a couple different groups. And you all know we have traits for our hair color, for the color of our eyes. We actually also all have traits for like platelet counts. Are we in the upper limit of normal or lower limit of normal? Red cell counts, sort of like blue eyes, high red cell counts, low red cell count. So some of our traits are contributing to what happens if we acquire JAK. So, and our traits, of course, are inherited. If you have blue eyes, one of your parents has blue eyes. If you have brown, same thing. So these traits for blood counts are being inherited. And then, we think we see from large population studies, we did a big one at Hopkins with over 600 patients and see that there is an increased incidence. If there is a family member, it's very low. But it's there. It's increased, but it's not huge. And so these probably relate to traits. We know there are a few other genes that some people harbor that make them a little bit more responsive to inflammation, like receptors to inflammatory factors. And so if you're a little more inflamed, some of these receptors are like IL-6 receptors, you're a little bit more likely to get an MPN if you acquire a JAK mutation. Conversely, there are mutations you can have that actually dampen inflammatory signaling. So those people are a little bit protected. So it's a pretty complicated story, but I think it's fascinating. And I was really, really enthralled by the papers showing that traits in part dictate whether you get an MPN and what kind of MPN you get. So I do think that now most of us who know the field agree there are some genetic predispositions and even some genetic protections, and there's a whole host of things left to learn about this. I think this is just the tip of the iceberg.
I do too. Nicole, do you have anything to add to that?
Yeah, no, everything Linda said is spot on. And the only other thing I would say though is even with that, I still don't, like if a parent asks me, should I go test all my other kids? I don't usually recommend
Right,
that because
right,
it is still the rarer version of things. We still think
right.
it's more likely that it's not a familial thing, but there are absolutely families, like Anne was mentioning, where really like there's multiple people with MPNs and there's reasons that they're more prone to developing it.
Yeah. So thank you to our physicians here today. They were marvelous, and we will be doing more with them, especially since that paper. When is that paper being, it's out today?
No, I mean, literally, we got the email at 7 p.m. last night that it was accepted for publication.
Okay,
So it'll probably be I think it usually takes like a month or so
yeah,
at least to get it
but
out there.
it'll probably be at ASCO, and
I mean, what I will certainly do is email you
thank you,
when it's published and then it's
thank
out
you.
there, and then people could go to the link and look through it if they
Okay.
want.
I'd ask that you both stay on and listen to Cam's story. And then and if anyone has other questions, they can email me. I'll send them on to both of you, and that would be great. Thank you so very much, very much. Cam, thank you for being so patient, waiting to share your story. I met you several years ago. Actually, your mom reached out to us, and Cam is part of our Patient Advisory Council, and share your story with us, sweetie, about when you were diagnosed, where you are now.
Of course, yeah. First of all, I appreciate being here and listening to the advancements in research, and the paper and everything is just so cool to hear and be able to be a part of. But yeah, the quick rundown is I was diagnosed when I was 17 with ET at the time. I'm 25 now. It was right before I was about to go to college. So, that healthcare transition kind of topic is very timely with that. I had to be able to talk to my mom and get her to understand I need to go to the doctor. I'm good. I'll be okay. So that's very important, being able to be on top of, I can't, take this lightly. It's, important to be aware and cognizant of what's going on. But yeah, I was diagnosed. I had the JAK2 mutation. I had the bone marrow biopsy. Went to college, was maintaining with phlebotomies, daily aspirin. And, about a year or so later, turns out it was PV. So nothing really changed. I didn't have any other, treatment being done. It was still the aspirin, phlebotomies, maintenance, making sure counts don't get out of control. When it came to symptoms, it was a lot of the typical ones that you would be aware of, like headaches were pretty frequent, itchiness, floaters, fatigue in college was definitely pretty prevalent. And then, the transition was the COVID era. And that's when I felt my worst, to be honest. And I think that always coincides with the most important thing that I want to advocate for is, gratitude, being mentally aware of everything that you have, and just trying to be active and not let it, drag you down. Because the less you're active, hydration, exercise, eating healthy, the less you're doing that, the more you're going to feel it. But day to day, I know I'm a normal guy, I would like to think. And so, I graduated college. I was moved down to North Carolina, just living life. Similar boat, was less social. I think it affects you more. The less you're active, the more you're going to feel like I have this. But you do need to know that you have it. You need to be aware of symptoms. You need to be aware of your counts. You can't take things lightly, but at the same time, you got to make sure you're enjoying your life and trying to do as best you can and communicate at all times, be transparent. Uh, and so recently, my spleen last year was actually the biggest it's been. I had my platelets reach well over 1 million for a few consecutive months. And I have Dr. Mascarenas in the city, and we decided to do some treatment. So speaking on interferon, I started Besremi in August of last year, and that's been pretty good. I did the slow transition of 50 micrograms and whatever, first, and then I now have 100. And I've been doing that bi-weekly. It's super seamless, and there's really not many issues by any means. My counts have stabilized, and I need to just check in on my spleen, but I believe based on how I feel that it's definitely way smaller. So pretty good stuff. But that's the quick breakdown.
Well, I have a couple questions for you.
Mhm.
One is when you were diagnosed and, as you got older and maybe during college or after college, and I know your generation is was particularly affected by COVID,
Mhm.
and for very specific reasons. The antisocial part of it at an age when you're the most social, school, all those things.
Mhm.
And I wondered how you navigated through that. And as a person with an MPN that wasn't so pleasant necessarily, how did you navigate through that?
Yeah, I definitely just relied on the friends that I had, and I was in school. I wanted to make sure that I was still focused on that, and again, just make the most of the situation and be very cautious and careful, but also not, be overwhelmed and anxiety take over and let stress take over, which I did to an extent, to be fair. But it's all going back to the gratitude, take advantage of what you could focus on outside of what's going wrong.
I want to hire you, right? I adore him. But you know what? All the young people I've met in this space are just terrific. And Cam, you are just a shining star for us at our organization. You always have been. And one other question came through, and that is, do you find yourself helping your parents, like making them calmer and not getting them upset about your MPN diagnosis?
Yeah, so the whole parent thing is very interesting from the child perspective because I am a very calm, or try to be calm, person and take things at face value and rationalize and break things down. And my mom, being a mother, is very nervous, and so I always try my best to reassure her that I'm okay. I think it's very important to be honest though. So I will be honest with her, like, when my spleen was enlarged, I'd made it known, like, hey, I'm actually like super bloated, I'm getting full, or like, I have bad itching. Like, when things were astray, I'm going to always communicate, but I'm always going to assure her that it's part of this and it's going to be okay. One of the
Yeah.
biggest things was always the counts. That always concerns parents. I'm sure you guys could attest to that. Um, but at the end of the day, the doctor knows that it's going to, if it's out of control, they'll let you know, they're going to figure it out. They're there and they're going to be supporting you through. So when my platelets were over 1 million, she was always nervous, and I kept telling her, listen, it's okay. I don't have any symptoms out of the norm. I still have my headaches twice a week or whatever it was at the time, and I'm okay. And I'll let you know if I'm not. So that's always the key, just communicating.
Have your symptoms drastically subsided since you've been on Best Remy?
Yeah, so the biggest takeaway with Best Remy so far has been the counts. The counts drastically improved. I think my spleen's definitely decreased in size, although I can't confirm that for sure. Um, Other symptoms like day-to-day fatigue is definitely seemingly better. Um, yeah, I mean, like other things like floaters are still present. I don't know how that, impacts. And I'm still only 6 months in, so I think it's still going to take a little bit more time to fully figure itself out. But for the most part, I definitely feel like it's improving my day to day.
That's fantastic. So with 1 minute left, we will hear from Cam in our next newsletter, we hope. I know
Mhm.
we've been communicating about that. And Doctors Nicole and Resar, I can't thank you enough again, all three of you here today. This was really, really wonderful, and we need to do it more often, and we will. And we'll be in touch. And again, if you have questions that were not answered today, you can send those and I'll send them onto our MPN specialists or to Cam. Thank you all very much.
Have a good day,
you.
everyone.
Bye for
Yeah.
now.
Thanks for sharing. Good advice to people with and without MPN, really.
Yeah, truly.
Appreciate all you
truly.
guys do. It's very cool to hear and see the advancements. So
I
thank you.
know, it was great, really great. I'm excited. I'll talk to you soon, Cam. We'll be in
Yeah.
touch with both of you. Take
Thanks.
care.
Bye.
Bye.
Bye.